Thank you, Dr. Priyanka, for welcoming me.
You're welcome. And today we'll be discussing about MDR tuberculosis, and Dr. Ramjit will be helping us to understand the different kind of definition to MDR tuberculosis, what are the regimen available to us, and a newer kind of formulation to drug-resistant tuberculosis. So, Dr. Ramjit, starting with our episode, can you please summarize about the different kind of drug-resistant tuberculosis that has been provided by WHO?
Yes, regarding the definitions of drug resistance tuberculosis, WHO have classified this into like 4 or 5 classes, like drug resistance, monoresistance, polyresistance, MDR, pre-XDR, and XDR. So, depending upon which drugs these bacilli are susceptible or resistance, they have classified this. Like let's suppose one patient is resistant to isoniazid only, then it is monoresistance. Only resistance to pyrazinamide, monoresistance. But let's suppose one person is resistant to rifampin, then we can't call it monoresistance. Why? Because rifampin is a very good drug for TB bacilli. Means if bacilli is resistant to rifampin, it means that these bacilli are also resistant to other drugs like isoniazid. That's why even in the study they have found like 70 to 80% of the TB bacilli which is resistant to rifampin are also resistant to isoniazid. So they classify those group of patients into multi-drug resistance tuberculosis rather than only monoresistance. And regarding the definition of pre-XDR, so in addition to isoniazid, rifampin, if patient is resistant to also fluoroquinolones like levofloxacin, moxifloxacin, and one injectable like amikacin or streptomycin, then we call it pre-XDR tuberculosis. And the definition of XDR tuberculosis means all 4 these drugs: injectable, fluoroquinolones, isoniazid, rifampin. So if these patient is resistant to all those 4, extensively resistance. So as the name implies, it is extensively drug resistance. And nowadays we don't use more often these injectable agents like amikacin, streptomycin, because we are now shifting towards all oral regimens because of the convenience of the patient, toxicity profile of these aminoglycosides. So nowadays they use bedaquiline, linezolid, because those are also highly efficacious anti-tubercular drugs. And so, if patient is resistant to bedaquiline or linezolid or levofloxacin, moxifloxacin, fluoroquinolones, and isoniazid, rifampin, then we can also call it extensively drug resistance tuberculosis. So I hope this you understand about this definition.
It's very important to understand that there is a term called as monoresistant drug-resistant tuberculosis. We also have monoresistant tuberculosis. So apart from rifampicin, if they are resistant to any of the anti-tuberculosis drug, then it is called as monoresistant. But if there is a resistance to rifampicin, then it is considered a multi-drug resistant tuberculosis, right?
Yes.
So this is a very important point to be understood. And there is also a term called as polyresistant tuberculosis, and it is quite different from the multi-drug resistant tuberculosis. So can you please put a light over it?
Yeah, polyresistance means like isoniazid plus rifampin, isoniazid plus pyrazinamide. But if it is isoniazid plus rifampin, then we call it obviously MDR. We already told, we discussed it. So, but like other apart from rifampin, if it is resistance to other 2 or more drugs, then we call it polyresistance.
So multi-drug resistant and polydrug resistant are not the synonymous term, right?
Yeah.
It is a different thing that we need to
According to
understand.
WHO definition.
According to the WHO
Yes.
definition. So, Dr. Ranjit, can you please elaborate on what kind of patient, when do we suspect that the patient has multi-drug resistant tuberculosis?
See, regarding this, whether we have to look whether patient has previously acquired tuberculosis, is it, I mean to say that it is relapse case. Sometimes patients have multiple episodes of tuberculosis. Even if you treat it for 6 months, patient is alright for 2 years, 3 years, then again has tuberculosis, and again treated for 6 months, again has tuberculosis. So in those types of relapse cases, we have to suspect resistance, MDR tuberculosis. And let's suppose we have started isoniazid, rifampin, those drugs. Those are called
As per our protocol.
yes, as per your guideline you have started. but patient's clinical status is deteriorating. Radiologically, if you see that it is not improving, or even if it is not progressing, worsening, new cavitations are forming, it is disseminated, you are seeing the disseminated pattern in the radiographic picture. Then also you have to think of multi-drug resistance tuberculosis, and you know that I have also worked in peripheral setup of this country, and one problem that I have seen is that the patient come to primary health center for taking these regimens, to SRHD regimens. They take it for 1 month and then they go home, and they sometimes lost to follow might be due to multiple reasons, and that I can't comment. So
sometimes geography might also
yeah.
affect, because the health center is located in one part of their place and their home is located somewhere far away, and there might be some difficulty in transportation. I don't think that people will be able to come on day-to-day basis to the health center and receive their treatment under surveillance, right?
Yes, yes. So those are multiple factors. Due to those, also I think that proper supervision is not being undertaken, and this is also one of the factor that is contributing to drug resistance tuberculosis in our locality, in our setup.
So, what kind of population are susceptible to drug-resistant tuberculosis? As we know, when do we suspect, as we have discussed, when do we suspect drug-resistant tuberculosis, but there must be some kind of population who are more prone to drug-resistant tuberculosis. Is there any so?
Yes, like let's suppose is HIV patients or immunosuppressed patients, those groups of patients, and plus if there is a local prevalence of high resistance pattern, like I mean to say that if in certain areas or certain localities there may be high prevalence of MDR tuberculosis, it differs depending upon the locations. So in those localities, if we look the epidemiological profile, then we can guess that in these locations, in these populations, it can be high chance of the MDR tuberculosis, and we might need to initially start empirical treatment targeting that MDR TB bacilli in the first place, rather than going for those drug susceptibility tests and then again changing to those MDR TB regimens.
Okay, so sometimes based on the patient clinical profile, we need to start ATT empirically. So before starting the ATT empirically, it's very important to understand the prevalence of drug-resistant tuberculosis in the community in which the patient resides, right? So based upon the prevalence of the drug-resistant tuberculosis, the patient might need different kind of regimen that we currently use for tuberculosis suspected patient.
Yes.
So there's different groups of anti-tuberculosis drug-resistant tuberculosis that has to be provided by WHO. So could you please classify?
Yes. Regarding the classification given by WHO, they have classified into Group A, Group B, Group C, and they have classified based on susceptibility pattern. Like if you say bedaquiline, linezolid, or fluoroquinolones, these drugs those TB bacilli are highly susceptible to these kinds of drugs. That's why they are kept in Group A. And if you see Group B drugs like chlorphazimine, cycloserine, or terazoledone, they come after Group A. If you give 3 plus point to A Group A drugs, then you give 2 plus and then 1 plus. And as you come down on this list, they are basically less susceptible. And I mean to say that those groups of drugs are highly, bacteria are highly susceptible.
Okay, so these groups, as per WHO, is divided into Group A, Group B, and Group C, and this list is based on a descending order.
Yes.
So basically, it's a descending order on the basis of drug susceptibility. So from this list, we understand that levofloxacin or moxifloxacin are the most susceptible these bacilli are more susceptible to levofloxacin or moxifloxacin, and they're least
Yeah, yes, you understood right. And regarding this list, I like to tell you that previously WHO has also included amoxicillin plus clavulanic acid, caprimycin, kanamycin in this list, but they removed it later because of those toxicity profile and less susceptible pattern they found later. So they removed this, but still they have kept this in this three classification system.
Yes, so injectable medications has been removed. Basically, we need to understand that they have tried to remove the injectable medication from the regimen, right?
Yes, initially, but you can see medication is still there. In the initially they have tried to remove it. But if let's suppose if a patient is hypersensitivity to chlorphazimine, hypersensitivity to cycloserine, or can't tolerate due to hepatotoxicity or other reasons, then we have to do permutation and combination among these to make at least 4 or 5 or 6 drugs combination, because we can't give one or two drugs to treat tuberculosis bacilli, and it is well known fact.
Okay. So we at the initiation of this episode, we talked about the different kind of drug-resistant tuberculosis. So how do we manage such resistant tuberculosis? How do we manage monoresistant tuberculosis? How do we manage MDR? How do we manage polyresistant tuberculosis?
Yes, you raised the right question, and we have initially classified this. The WHO classified this for this treatment purpose. Let's suppose IUD patient is resistant to isoniazid. Then obviously you can't give isoniazid. Then remaining three like rifampicin, pyrazinamide, ethambutol you can give, and plus add one fluoroquinolone. As you already told that these fluoroquinolones they come in number 1. So add one fluoroquinolone in addition to RZE and give it for 6 months. So that can be one option. But in HIV positive patients, you have to prolong the duration to extra 3 months. And the next option can be patient can't tolerate pyrazinamide. If a patient is isoniazid resistant and cannot tolerate pyrazinamide, then you have to eliminate both isoniazid and pyrazinamide. Then you can give rifampicin, ethambutol plus fluoroquinolone for 9 to 12 months. So it is regarding isoniazid monoresistance. Similarly, if rifampicin monoresistance, then I already told that this is according to MDR TB regimen. And if it is pyrazinamide resistance, then remove pyrazinamide, give isoniazid rifampicin for 9 months.
Okay.
And
this is polyresistant tuberculosis.
yes. So in addition to resistance to isoniazid, if it is other resistance to others like besides rifampicin, in the definition we talked that we have to remove rifampicin because we discussed those in MDR TB. So let's suppose if it is resistance to isoniazid plus ethambutol, then if we can't give isoniazid ethambutol, then we have to give rifampicin, pyrazinamide, and one fluoroquinolone for 6 to 9 months. If resistance to isoniazid, pyrazinamide, then we have to give rifampicin, ethambutol, and fluoroquinolones for 9 to 12 months. If resistance to EZ, then we can give rifampicin plus fluoroquinolones, and among these three, ethanamide, dimethyl chlorphazimine, we can give 2 for 9 to 12 months.
Yes. So now we'll be moving about. So there are multiple different kinds of regimen for multi-drug-resistant tuberculosis. There's a short course regimen and there's a long course regimen. So can you please put a light over what is the regimen that we use for short course regimen? What is the duration of treatment? And what is the duration for the longer course treatment? And what is the regimen available for the longer course treatment?
Yes, you are pointed out rightly, shorter course and longer course regimen. And apart from that, we also are transitioning to abbreviated regimen, that is all oral regimen, that is upcoming topic. And recently also one TB practical trial was published, and they have shown it is better than those shorter or longer course regimen. So we'll discuss later those things, but here I'd like to address your query about shorter and longer course regimens. So regarding the shorter versus longer course regimen, as we saw in the group system A, B, C, so they have done permutation combination of those drugs to make shorter course and longer course regimen. Shorter means we can remember like that. Shorter means 1 year, longer means 2 years. Actually, this is like 9 to 11 months shorter. But for remembering purpose, 1 year we can remember like 2 years. So shorter course regimen is intensive phase 4 to 6 months and continuation phase is 5 months.
Intensive phase 4 to
6 months and continuation phase
is 5 months.
yes. So so you might be wondering why 4 to 6 months.
Yes.
So when to give 6 months and when to give 4 months. So that depends upon the sputum conversion rate. Like if we do a sputum ERP test and at the end of 4 months if it is still positive,
Okay.
then we might need to extend it to intensive phase to 6 months. So
It depends upon the sputum conversion at the end of the 4 months, right?
yes, here we have written that follow-up smear at microscopy at 4 months. If it is positive, then we have to extend extra 2 months.
Yeah, we have to, if there's a positive, there's no sputum smear conversion at the 4-month duration after continuation phase, then we have to prolong the continuation phase by the 2 more months.
Yes. So intensive phase is 4 to 6 months and continuation phase is 5 months. So in intensive phase, as we already saw that beta cuisine,
Yes.
this is one of the group A class, and then fluoroquinolones, levofloxacin. So those beta cuisine plus levofloxacin. In addition to that, say group B, clofazimine, and group C, pyrazinamide, ethambutol, high dose isoniazid, and ethionamide. These we give for 4 to 6 months. And then in continuation phase, we give this fixed regimen: levofloxacin, pyrazinamide, ethambutol, and clofazimine. Here also we can see one is from group A, levofloxacin, clofazimine is from group B, and pyrazinamide, ethambutol, this is from group C. So this we give for 5 months. But the problem with this shorter course regimen is that you cannot tinker the drugs among these.
We cannot alter any drugs. It has to be like this research.
Yes.
If there's some intolerance to any of these drugs, then we cannot bring the drug from the group B or group C and add on to this regimen.
Yeah.
Yeah.
And let's suppose patient is resistant to levofloxacin or patient has hypersensitivity to pyrazinamide, then you cannot use this regimen because this is a fixed regimen. Because this has come from just a randomized controlled trial and they have found this beneficial. So if you want to use those in those category of patients, you have to use like that. In longer course regimen, we can tweak the two permutation combination based upon the tolerability, availability, susceptibility pattern. But here, either you use it or don't use it.
That's really important point to be understood. So now moving on to longer regimen.
Yes. So before that, when to use shorter course regimen, will it be helpful or?
Yeah, of course. So there are some conditions. We definitely have two regimens, shorter regimen and longer course regimen. So it depends upon. So it's not like that we can use any of those regimens. There are certain conditions in which shorter course regimen are contraindicated. Is that right?
Yes.
So what are those?
So in that study, what they have done that they excluded pregnant patients and children less than age of 5 years, or if patient had already received these drugs like levofloxacin, ethionamide, clofazimine for greater than 1 month due to other conditions like pneumonia or any other conditions like UTI or whatever infection may be. If they have received this for greater than 1 month, in those category of patients they did not include. So we don't know the result regarding those group of patients, and they also excluded severe tuberculosis, extrapulmonary tuberculosis, CNS tuberculosis, biliary tuberculosis. So we also don't know the result regarding those groups of patients. So and obviously intolerance to any drugs in this class, so we cannot give this. So and another point is CAT-G and INHA mutation. So if isoniazid resistance, both CAT-G and INHA resistance, then mutation, then in this group of patients also we can't give shorter course regimen.
So shorter course regimen can be used only when there is a resistance to either of CAT-G or
Yes.
isoniazid, and it should be used only in those with uncomplicated MDR TB.
Yes.
Right? And it is excluded in pregnancy. It is excluded in pregnancy and also in children below 5 years. And those patients who have used levofloxacin, clofazimine, or
Ethionamide
for longer than 1 month, those population are also excluded.
and also intolerance to drugs.
Intolerance to drugs.
Yes. Yes, so I already told that the benefit of non-tuberculosis regimen. This you can see this levofloxacin, bedaquiline, linezolid. These are group A drugs, and this clofazimine, cycloserine group B drugs. So they have included this based on that classification system of WHO. And here the point that we need to understand is that let's suppose patient is hypersensitive to linezolid. Then we can remove linezolid, we can add drug from group C drugs. Yeah. If it is patient cannot tolerate clofazimine, then we can remove this and keep another drug from group C class. So this is the advantage. We have to keep like 5 or 6 drugs, but we can tweak it depending upon the
make our regimen from those drugs based upon the patient profile.
And availability of the drug and toxicity, side effect. Yes.
Yeah. But the duration is longer. That is 18.
Yes, that is one disadvantage. Yes.
So as you have previously mentioned about the abbreviated regimen for the multi-drug resistant tuberculosis, and it seems like it has a good result in recent trials that has been published. So can we have a little summary about the abbreviated regimen?
Yes, I also feel delighted to talk about this abbreviated regimen, and recently one TB practical study was published, and they saw that this BPAL-EM regimen is superior. They actually did non-inferiority trial with 12% non-inferiority margin, and what they found that it is also non-inferior and even superior to standard care regimen.
So the regimen was it was done. They compared it with the standard of care
Yes.
regimen, and they had two. If I am not right, then it had 2 stages of study. Right?
Yes, it's 2 stages, and in first stage they compared with BPAL. BPAL means bedaquiline, protomanic, linezolid, and BPAL-M means moxicloxacin.
Yeah, they had 4
groups.
There are
Yes.
4 groups.
4 arms, you can say.
4 arms. Yeah.
Yes. So BPAL-M, BPAL plus clofazimine, and standard care. And what they found that this BPAL regimen, BPAL-M regimen, BPAL clofazimine, all are superior to this standard care regimen, that this is short course or longer course regimen that we are using in our setup. And BPAL-M is superior to other. If you use BPAL plus moxicloxacin, this has been found to be superior to standard care regimen and other. Like even BPAL, compared to BPAL, if you add moxicloxacin, this has some more favorable outcomes, and also toxicity profile is not that much statistically significant difference. So definitely this is the future of MDR TB treatment.
Yes. So in that trial, they basically compared all the 4 arms. Then in the second stage, I think they compared BPAL-M with the standard of care, right?
Yes, yes. And they found it favorable outcome with not much toxicity profile.
So can you please talk about the TB practical?
Yes, yes. So this is the table that I have taken from this trial that has been published in the NEGM, and you can see they have done intention to treat, modified intention to treat, protocol analysis. In all, they found that they have good favorable outcome, and on the side effect profile, they are also less in this BPAL-EM regimen compared to a standard care regimen. So,
no, this is basically about the BPAL-M regimen, right?
yes, yes. And you can see here WHO has also endorsed and approved this BPAL-EM regimen for MDR TB treatment if age is greater than 40 years and there is no severe extrapulmonary tuberculosis and serious meningitis. In those group of patients, we can use moxicloxacin plus BPAL regimen.
And the duration is also very short. It's about 6 months duration.
Yes, it's 24 weeks. Yes, it's 24 weeks all oral regimen. That is the main crux of this trial.
So I hope that we soon have this regimen at our place, because it seems very patient friendly, and as the duration is shorter and all over the regimen, I think the patient compliance will be high, which might result in the long term to decrease the incidence or prevalence of drug-resistant tuberculosis.
Yes, obviously it will be very good if it can be available in our setup. And regarding abbreviated regimen, what I like to talk, one ciprofloxacin was in group A and paraxinametloxam group C. So they have included group A and group C regimen, and the thing is that these are all oral regimen for 9 months, and they also have found it can be good acceptable alternative to those shorter or longer course regimen which are cumbersome, take about even about 20 tablets, and so definitely this abbreviated regimen, I think this is the future of the MDR TB.
So there have been multiple studies regarding multiple combination therapy for
Yes.
create a sort of course
And
therapy.
there are multiple RCT have been done, and multiple RCT is still going on to bring about less toxic drugs and less. They are reducing the time duration, and yes, so making patient friendly and shortening the time duration.
And they have basically excluded all the injectable drugs from the upcoming newer regimen therapy, right?
Yes, yes. And
So it was a very wonderful session, Dr. Adit, and I understood a lot about drug-resistant tuberculosis, and we have simplified and made it very understandable. And I would like to thank you for that. And so in today's section, we understood, we learned about the different kind of different definitions that has been provided by the WHO, different groups of drugs that have been provided by WHO, that is group B, group B, and group C, and how we manage the different kind of drug-resistant tuberculosis. And we also talked about the different regimen, short and longer courses regimen, and the most upcoming booming topic, that is abbreviated drug-resistant tuberculosis. We also talked about that, and TB practical trial, which has shown very better results compared to standard of care. So it was a very wonderful session, and I would like to thank you again for this session, Dr. Adit. And so do you have to say anything?
yes, I also like to thank you for providing me this wonderful opportunity, for giving me opportunity to talk on this topic, and I also feel delighted to talk about these things, and I am more fascinated toward this abbreviated regimen that is upcoming, because that will definitely, I think it will change the management of drug MDR tuberculosis treatment. So I am optimistic about this treatment regimens, and in the last I like to thank you.
You're welcome, and I hope it was very useful to our audiences as well, and we tried to make it simplified so it will be very understandable to our audiences. And in next episode we will be talking about